Hello, my name is Jessica Rivera, and this is my presentation on HIE and interoperability. As we continue to move forward into the digital and electronic ages of healthcare, we face new and challenging conditions that encourage us to do better as an industry. The largest part of what's currently driving innovation within healthcare information is the need to create databases, applications, and systems designed around the need for seamless patient data transfer in order to reduce cost, improve patient care, increase revenue, and employ more communication between providers, patients, third-party payers, and other stakeholders. Here we will define some of the key components needed to implement these changes and how they can better serve our community. First of all, what is the Health Information Exchange, or HIE? According to healthit.gov that was accessed in 2021, Electronic Health Information Exchange allows doctors, nurses, pharmacists, or other care providers and patients to appropriately access and securely share patients' vital medical information electronically. A large database is created and maintained that allows those with access to the information to a near complete picture of a patient's medical chart, including PHI, current treatment and diagnoses, payer information, and more, without having to go through all the standard processes of waiting for faxed information, in some cases waiting for mail-in, and in some cases allowing all providers within that system to see the information on a patient without having to do multiple requests of information. Right now, there are three different types of exchanges. There's a directed exchange, which is the ability to send and receive secure information between providers in order to coordinate care. For example, if you need to have a specialist referral, say to a cardiologist, your primary care doctor can send the direct information orders to the cardiologist through an HIE, and anytime the cardiologist updates information or puts it into a system, that information can be directly rerouted back to primary care providers, so both providers have instant access to all information at once. The second one is a query-based exchange, an ability for providers to search for and find patient information from all other providers within an HIE. So again, if your primary care provider wants to see if there's been any other doctors that you've seen, any hospital visits that you weren't aware of, or anything else like that, they can do a quick search based off of your patient information. For example, your date of birth, your social, or your master patient index number, and see if there's any information that's already been updated into the HIE in order to update his own records or give him more information. The last one is a consumer-mediated exchange, so the ability for patients to control and aggregate their data between providers. This can be in the forms of patient portals at times, although those are a little bit more controlled because patients don't always know what information to put into it, or it can just be as simple as a request or an authorization from a patient to say, yes, all providers within my HIE have full access to my data, or they can say, well, I believe that my provider is already part of this system. Can you go ahead and pull the information from him that way? Right now, there are 5-6 different levels or 5 different examples of HIEs that are currently working in Texas. There are links to all these within the file, so you're more than welcome to check out each one of those individually. But there's the Greater Houston Health Connect, HASA, PHIX, which was formerly known as the Paso del Norte HIE, Integrated Care Collaboration, Rio Grande Valley HIE, and then there's also a state level HIE, which is operated by the Texas Health Services Authority, or also known as THSA. On a federal level, we mostly have the one main exchange, which is the eHealth Exchange. But supporting eHealth Exchange are services such as Commonwealth Health Alliance and Care Quality. Commonwealth is a data alliance that is more focused on breaking down some of the technical barriers, some of the language barriers between the different systems, focusing more on standardizations of the HL7 FHIR network in order to make sure that there's a standard for CCDA across the board to make it easier for the information to be exchanged. Care Quality is interoperability framework adopters, so they're actually helping build out the framework and getting other people on board to do the same thing. And the Health Exchange, of course, is a network of networks, so it Each HIE should, in theory, be connected to the eHealth exchange in order to further promote interoperability throughout the states, not just within the state itself. So I guess the question now is, what exactly is interoperability? My definition of interoperability is the seamless, lossless, accurate, and timely exchange of information between disparate sources, systems, and applications. In terms of healthcare, interoperability is the goal of each health system to be able to communicate patient and providers' information in a near instant manner to provide the timeliest and cost-effective patient care without reducing or losing quality of patient data. So in its barest term, interoperability is getting the systems to talk to and understand each other at the times that they need to be understood and communicate. So how does interoperability work within the HIEs? The HIEs are designed to transfer patient data between systems that have already agreed to work with each other, which is interoperability within those systems. Now, this can include everything from pay information such as Blue Cross Blue Shield and Aetna, local hospital systems like Baylor Green, Scott and White, and United Healthcare. And it could be your locally owned pharmacy, mom and pop's pharmacy down the road, and your primary health care providers. These people have already agreed to share and exchange appropriate patient information, and at times they've even agreed to what formats to set up their application. This again goes back to the working on the agreement on CCDA standards, so that way everybody's using the same format and forms, so that way when one gets sent to another, it's not getting lost because they weren't set up that way or they write theirs a little differently. So how do these come about? Well, the Office of the National Coordinator really focused on meaningful use, which was an incentive program designed by CMS to encourage health organizations, large and small, if they use the Medicare and Medicare services, to move away from paper records to a more efficient EMR or EHR system. Originally designed with incentives and penalties for those who didn't move away from paper records, the ME program eventually evolved from not only using technology to store and transmit information, but according to the AMA Association, increase the exchange of information and continuous quality improvement at the point of care. If you see the little blurb of images on the side, they were working on efficiency, improving the public health, reducing health disparities, double records, inappropriate records, everything that we see as far as coding in order to reduce the options of not getting paid, safety and security, helping engage patients on informational level as well as patient portals. And again, the overall goal is to improve quality of patient care. After the first two phases, ONC moved on to what they're calling their promoting interoperability phase. It's more apt to reflect its current goals. These goals are updated yearly, and the 2021 goals are as followed in order to meet the current criteria. So a minimum EHR reporting period of any consecutive 90 days for new and returning participants. Needs to report on 4 objectives and their associated measures: electronic prescribing, how they're doing when it comes to health information exchange, provider to patient exchange, which focuses more on patient portals and access and then updated information on that, and public health and clinical data exchange. We see a lot of that right now with the ongoing pandemic on how to capture data, what data is used, and how it still protects patient privacy when it comes to the public health. Now, eligible hospitals and CHs may use one existing 2015 criteria, the 2015 edition cure update criteria, or combination of two in order to meet the definitions as finalized in 2021. But that is temporary. You might see that be going away as it updates from year to year and new requirements are met. It does need to report on 4 self-selected electronic clinical quality measures from 2 self-selected quarters of the 2021 calendar year. And then it has to submit yes to the following: that it has done a security risk analysis measure, prevention of information blocking attestations. That means it's not doing anything to prevent patient data from being received. and the ONC direct review attestation. So it does need those in order to meet the current criteria to help promote interoperability between these networks. Now, this was last updated in 2019, but it actually goes all the way back to 2015. HealthIT.gov created an infographic that just had a very basic, what looks like a roadmap to say where we were, where do we want to go, what are some examples. You can actually see the link on the page that will take you to the full infographic. This is just a snippet of it, but it gives some examples of, at the time, 94% of non-federal acute care hospitals use a certified EHR to collect electronic data, which is good. We look further to the right, we'll see in 2013, more than 6 in 10 hospitals electronically exchanged information with other providers outside their system, which is, again, very good. But if you look in the middle of it, it says 51%, only half of hospitals can electronically search for critical health information from outside sources. So they cannot find or have access to information outside of their personal systems or their specific HIEs in order to gather more patient information. You do again go to the link on the page, you can see the full roadmap and where some of the goals are going to be by the end of 2017. Again, we are a little bit past that, but it's a good idea of where we started. So October 2020, the ONC also created the Federal Health IT Strategic Plan that explains how the federal government intends on using health IT to implement the following. Again, you can find more information on this and read the full report on healthit.gov underneath the Federal Health IT Strategic Plan, but they are using these 4 main steps: promoting health and wellness within the community, within the American community, enhancing the delivery and experience of care, building a secure data-driven ecosystem to accelerate research and innovation. This is within the health community as well as within the health information community as well. And connecting healthcare with health data, because these tend to be 2 very disparate systems. Healthcare people will sit there and say, well, my healthcare only has to do with what my doctor tells me, what medications I've prescribed and what conditions I have. The data-driven aspect of that informs the patients on how to better manage their healthcare, better manage their health expenses, and creates a more cohesive quality amount of care. Now, what does this mean for our future? This is my own personal interpretation of this and how I view the future of interoperability in HIEs. The goal of interoperability is a lofty one: get all systems to communicate effectively while keeping the privacy and security of patients' information intact, while also protecting the revenues, trademarks, and organizational preferences and ecosystems of the health systems intact. It's a big bite to chew. We have to worry about not only what is best for the patient, which should always be first and foremost in our head, but if the organizations cannot support the structure in order to do these things, they go down and we lose the patients in the process. So it is a delicate balance and one that's not easily achieved. I think if we do remember that the goal is what's best for the patient, the rest will fall into balance, because healthcare is absolutely needed. There will always be someone in need of a provider, of a nurse, of a Band-Aid or a cancer treatment, and everything in between. If we were focused on the goal of what's best for the patient, then the interoperability, the seamless transfer of information should be easier to achieve. I'm not saying easy by any means, but easier. I hope you all enjoyed the presentation. You'll have a wonderful day.